It is a great pleasure for me to be here today and be part of this great program and to support this wonderful organization. I really didn't know until this morning just what you folks have accomplished and what you're trying to do, so I'm humbled to be here. My message is one of trying to fill a gap that I think exists in cancer care in this country. It is slowly closing, and that's the gap that's related to risk assessment, risk management, genetics, that sort of thing. We can do a fantastic job of imaging and pathology and surgery and chemo and radiation and survivorship and social work support and all that. In my opinion, in that circle, if we're not attending to the risk assessment. When I hear stories of Coletta, all right, and I think back on all the Colettas I have known and taken care of, and how many times, when all was said and done, that she did not ever have to meet somebody like me, right? That we could have been out in front of it and prevented the cancers that were destined to occur. So over the last number of years, I have dedicated my professional practice, my life, to not only taking care of those patients, but to educate others with what we accomplish in Kansas City to help them help these patients and these families. I know from what Tara asked that we have mostly nurses. Therein lies part of the problem, that we don't have more physicians coming to a program like this. But let me reemphasize for those of you involved in the nursing level of care, that you hold a key place in getting all of this done. And I hope that you learned something along the way here today. My talk's going to be primarily clinical. You're going to meet a lot of people in my talk, all right? And just to let you know, the cases are real and the names are real as well, because that's what keeps it real for me. I am on the Speaker Bureau for Myriad Genetics, so they support me in my endeavor to help change this kind of thing across the country. Let's start with some of the more common hereditary cancer syndromes that we are aware of. I think probably everybody coming into the room today has heard of the BRCA genes, right? The breast cancer genes, they're in the news, right? The hereditary breast ovary syndrome. There are a few other cancers that make up that syndrome. It's not just about breast cancer. A second syndrome called Lynch syndrome, where the primary cancer is colon cancer. Different set of genes, different set of cancers. I'm going to focus on that one a little bit more today because this is Colon Cancer Awareness Month, all right? And this holds a special place for me. And then the colon polyp syndromes, where people are genetically programmed to make lots and lots of colon polyps and be at high risk for cancer. So as I go around the country and talk to clinical groups, these are the three that most people say, yeah, I've at least heard of those. I have some handle. I may or may not have a working knowledge. What is the impact of having a bad gene? So this happens to be a curve of breast cancer risk, all right? Across the bottom is age, and up is breast cancer risk. The blue line is the average American woman with a lifetime risk roughly 10%. The red line is my mother had breast cancer or my sister had breast cancer, therefore my risk is a little higher. The green line is I was born with one of those bad BRCA genes. And you can see how much higher the breast cancer risk is. Lifetime risk approaches 80%. You can also see how much younger the cancers start, all right? And this is typical of what we call a high penetrance cancer gene. That is, you're born with it, you are literally standing on the railroad tracks and the trains are coming, all right? And our goal is to find the people on this curve before they get their cancer so that we can intervene and do something different. You know, as an oncologist for all these years, we spend the bulk of our time chasing cancer, right? That's what we do. When the people get to us, it's already too late to prevent it. And I always wanted to be, like I said, on the other side of that fence. But breast cancer is not all about BRCA these days. We have a whole handful of other breast cancer genes listed here. You may or may not recognize any of them. That's not important, but to know that they're there. And on the surface, it may seem, golly, it's gotten a lot more complicated now. It was always about BRCA, and now there's so much more. One of the things, the paradox of that is that even as it seems to get more complicated, our ability to solve the family puzzle and figure out what we're dealing with is getting ever easier, right? And therefore more available to more and more physicians and nurses. Here's a similar curve for ovarian cancer in women who carry a bad BRCA gene. And you can see that here's the normal woman in blue again, a lifetime risk of about 1%. A woman carrying a BRCA2 mutation, lifetime risk about 20%, and BRCA1 about 40%. 40 times higher than the normal woman, right? You think it's important that we find the people that are on these curves and keep them from getting this cancer that is not one of our great success stories. Not to leave colon out, here's a similar curve for average colon cancer risk, about 5%. Lynch syndrome, which I mentioned, about 80% risk. Polyposis approaching 100%. So again, our goal is to find these folks. How would we know that we have one of these in front of us? So these are what I call, these are my version of the hallmarks of hereditary cancer. Number one, family clustering of certain kinds of cancer across the generations. Well, it's hereditary, right? So should there not be family clustering? And certainly that is the strong motivation for us to recommend better cancer family histories, right? Trying to get doctors and nurses to do this better. But I can tell you at the same time, I could show you case after case where there is no family clustering. How can that be? It be, right? And there's a variety of reasons why that's the case. And I can speak to my own practice and my group in Kansas City that in the days when all we were looking for was the slam dunk family history, we missed all kinds of people. And you're going to meet some of those people. Younger age. I showed you the curve of the cancer risk and how early it leaves the baseline in these hereditary situations. So a person getting cancer way before their time is an important clue. The flip side, however, don't be thinking that just because a woman gets, let's say, her first breast cancer at the age of 75, that can't be a hereditary cancer. All right, you saw the curve, it just keeps climbing, right? So some people, for whatever reason, don't get their cancer till later in life. So it's an important clue, but it's not exclusionary, if that makes sense. Multiple cancers in the same person. You're programmed to get it once, you're programmed to get it again. A second breast cancer, a second colon cancer, depending upon what you did with the first one. So that is an important thing. Or maybe the second cancer is one of those other cancers in that particular syndrome that I showed. And then lastly, typical phenotypes. You might not be familiar with that term. Phenotype refers to the characteristics of the cancer itself. Maybe it's the location of the cancer in that organ. Maybe it's what it looks like under the microscope. A perfect example would be so-called triple-negative breast cancer, highly associated with BRCA mutations. So these are the clues that we're looking for. And personally, that's too much for me to remember, so I bring it down to this, my little mnemonic, FAMP, FAMP, family, age, multiplicity, and phenotype, and that's what clicks off in my head as I'm looking at any given family to make sure I've covered all those bases. Again, why do we care? I've already alluded to the prevention aspect of this. I'll show you here just a group of cancers, fairly common cancers, breast, uterus, colon, ovary. These are cancers that we have highly effective strategies if we know who is at high risk that we can prevent. We may be able to do preventive surgery and remove the target organ. We may have medication that can lower cancer risk, tamoxifen for breast cancer, oral contraceptives for ovarian cancer, or at the very least, we may be able to do high-risk surveillance, breast MRIs, or more frequent colonoscopies would be examples. Okay? But here's the other part of this. It's not just about prevention. we're learning that some of these hereditary forms of cancer are biologically different than their non-hereditary counterparts. And that can affect prognosis. BRCA ovarian cancer, stage for stage, much better prognosis than non-BRCA ovarian cancer. Conversely, BRCA prostate cancer, for the two men in the audience, bad news, all right? Much worse prognosis. We don't know why, it's what we observe. We're still working on trying to figure that out. It can affect surgery management. Classic example would be the new breast cancer patient who might be a candidate for a lumpectomy, but as you hear about, they might also want to do a double mastectomy if they carry one of these bad genes. That's an example. And now it's kind of getting into my arena, all right? The chemotherapy part. We're learning that some hereditary cancers respond very differently to drugs than others. And that's infiltrating that decision making. That list is just going to keep getting longer as time goes by. So, if you want to have in the community a effective cancer genetics program, to me there are three components to be addressed. We got to find the right people to test. We have to test the right genes in order to solve that particular family puzzle. And we want to perform the testing of those genes in such a way to maximize the chance that we get the correct answer when all is said and done, okay? Finding the right people. Okay, so how many people should have genetic testing? If we take large groups, that is, let's look at all breast cancers, all colon cancers, et cetera, and we apply the guidelines, current guidelines coming from the NCCN, the mothership, how many people should have testing? For breast or colon cancer, about 25% at least. That's 1 out of 4. So if in your program, or whatever your sphere of influence is, you want to know how are we doing at this, take a time frame, a year, 2 years, how many breast cancer patients did we see, and how many had genetic testing? If you're in this ballpark, you're close, congratulations, you got a nice program. If you're like we were, down around 3%, then you got some work to do. Ovarian cancer, 100%. Every single patient with ovarian cancer needs genetic testing. Not most, not many, all. Pretty simple. Endometrial cancer, current guidelines would lead to about 2/3 to 3/4, 70% or so, meeting guidelines for genetic testing. All right? So I can tell you that around the country and in different kind of things, there are huge gaps between reality, what's going on, and what those target numbers are. So I ask, in whatever you do, how good are you? How good are your physicians, whatever, at finding these people? And I ask that question somewhat rhetorically to lead into how bad can somebody be at this? And let's point the finger right at us, all right, at Kansas City Cancer Center. This is some historical data brought to our attention by our nursing staff back in the mid-2000s. And I just want to highlight, let's say, 2004. What they did is a massive chart review of our entire practice in newly diagnosed patients. And you'll see that in 2004, we did genetic testing on 28 patients across the entire practice. We have 27 oncologists in our practice. That's 1 per doctor per year. But at the time, we thought we were right on the money. Yeah, that's about right. This is rare, right? Rare stuff. We're finding the slam dunk family history. We're sending off for testing. We're doing it. We couldn't have been more wrong. The next 2 years are similar. We won't go into the details on that. But it was in the 2006 timeframe that all this comes to light, and we have to fix it. This is a quality of care issue. We're not attending to that piece of the pie. And so we put in a program, and I use the term program loosely because all we decided to do was take better family histories, actually pay attention to the family histories, factor in age, factor in phenotype, that sort of thing. And I just want to show you, those here are what we call our genetic dark ages. And this is the last year of those dark age before we stepped into the light, because we started our program at the end of 2006. And see what happened over the course of the next few years in terms of the number of people tested and the number of people with cancer-causing genetic mutations that were identified. And that's just from deciding that we stink and we have to do better. We had a two-pronged approach. Newly diagnosed patients with cancer and everybody else. New cancer patients, is that not when we're taking the family history? Is that not when we're looking right at the age and the phenotype of the cancer? It's pretty easy at that point of attack to figure out who these people are. We take better family histories and we apply the so-called red flags, all right, which is sort of the practical application of family age multiplicity and phenotype. So you may have seen these. Here are the red flags for BRCA. Breast cancer by the age of 45. All breast cancers at 45 or younger are appropriate for testing. Here's every ovarian cancer. Males with breast cancer. Here's my triple negative breast cancer phenotype. Cancer in a Jewish woman, family history, etc. So these are not new. This is the way it's been for about 7 or 8 years with this particular group of red flags for BRCA. How about Lynch syndrome? Got red flags here as well. Family, age, multiplicity, and phenotype, there they are. That's what drives these things. But as an example, any patient with colon or uterine cancer, less than 50. Or any family with 3 Lynch cancers in the family, all right? And then there's some phenotype issues here as well. So there we go. By doing that, we found a whole lot of folks. Here was the second part of our program, which was everybody else. Because we've been really bad at this for a long time. So, okay, starting in 2006 or 2007, yeah, we're really good now on our new patients. What about the patients from last year? And 2 years ago, and 5 years ago, and 10 years ago, they're still walking around in our practice. How are we doing on those? Not so much. So we had to put in a program that allowed us to identify these people by systematically, and this is the way we did it, once a year we update their cancer history, personal cancer history if they've had it, or we update their family history, right? We take a gander at it. There's either something to talk about or there isn't. We move on. I will show you in a few minutes data from our practice from this part, the second prong. And every time I show it, it's mind-boggling to me. All right, I promised to meet some people. Let's meet Felicia. 32 years old with a new breast cancer. It's triple negative. It's big. It's growing. The kind of people that we give chemotherapy before surgery. She'd had a mammogram 8 months earlier, by the way, which was normal. And why is she getting a mammogram at 32? Because mom had breast cancer at 42. The old 10-year rule. Mom had 2 breast cancers, as a matter of fact. Aunt had ovarian. Grandma had breast cancer. Lots of red flags in that family. Here's the family tree. Felicia's there in yellow. Here's mom, aunt, grandma. Before I move on, let's just look at before Felicia, this little group right here. Look at that little clustering. F, do I have family? 1, 2, 3, yes. Do I have age? Age, all less than 50. Got multiplicity. How does this family get missed prior to Felicia's cancer? Who misses that cluster? We did. She was our patient. So was her sister. All right. So when you look at Felicia and her sister, who's taking care of them? Gynecologists. They recognized that family tree. That's why they had them under surveillance. They were watching them very closely. And yet she still got cancer right under their nose because they never actually solved the puzzle. Right? They never figured out what was going on. What do you think Felicia's sister thought at the time that Felicia, right under their nose, gets breast cancer? She's one of those ones that said, please sign me up for a double mastectomy right away. All right? If you ever hear about patients like that, they go, get me off this roller coaster. I don't want to be part of it. We had to talk her off the ledge while we sorted out the rest of the family. Anyway, Felicia gets put on some chemotherapy. Like I said, we would do standard treatment, response after one cycle. But Felicia, at the time she was diagnosed, had her genetic testing done literally the day her cancer was diagnosed. All right? That was the shift in our approach was, if this is going to be needed to affect management, we need to know it right away. And so our methodology was testing right out of the gate. We knew she was BRCA1 positive by the time she came back for her second cycle of chemotherapy. In my slides, a positive carrier is red, so you'll be able to follow through the family. Her chemotherapy was switched. Remember I said before that chemotherapy works differently in some of these? Here's a drug you may or may not be familiar with. It cisplatin. We don't use that in breast cancer much, except in BRCA-positive women. She was switched to cisplatin. Her cancer melted away, literally right before your eyes, like a lymphoma melts away. And at the time that she had her bilateral breast surgery, there was no evidence of cancer in her breast. Okay? So there's an example of it changing management when done in a timely fashion. Here's the rest of the family. Felicia's brother had the bad gene, so would his daughter. So here's our woman standing on the railroad tracks that we're going to be able to manage lifelong. We're not going to do double mastectomies at 22 or take her ovaries at 22, but we're going to start surveillance. And at some point in time, when she's had her children and she's done with that, we'll start talking about separating from her ovaries. And maybe there'll be some point along the way that she wants to do preventive mastectomy. Who knows how that will play. Interestingly, Felicia's sister did not have the mutation. So I throw out to you, what is Felicia's sister's risk for getting breast cancer? Look at that family history, how horrible it is. What is her sister's chance of getting breast cancer? Same as the general population, all right? So this cuts both ways. Not only does it allow us to find the person on the railroad track, on that high curve, it allows us to find the person in the family that's on the blue curve, the normal woman's curve, and we manage accordingly. How about Judy? I meant to have you put some wine in my tea before I talked about Judy. All right, so we'll get through Judy. 60 years old when Judy comes in for follow-up of her breast cancer. She'd had a previous mastectomy, chemotherapy. She had taken tamoxifen for 5 years. So she's now in routine follow-up. No other breast cancer in her family when she was diagnosed. Father had melanoma. Grandma had pancreas cancer. Look at the red flags. And I ask, what's missing in that little story? And I'm not trying to be coy, I'm trying to make a very significant point. What's missing there? Well, she wasn't genetically tested, but there were no red flags. Why would she be genetically tested? We don't have the ages of her father and grandmother. Her father was in her 50s, his 50s. I forget what grandma was. I think she was 60s or 70s. We'll see in a minute on the... oh, yeah. Her age when she was diagnosed with cancer. I tell you, she's 60 when she comes in. Who did she come into? Me. Judy was my patient. Judy had been my patient for a while. I had tried to release Judy back into the wild many times, all right, because she didn't need me anymore. She lived 100 miles away from Kansas City. But Judy wanted to come once a year and be blessed by the oncologist that all is well and do some shopping. All right, so, okay. Made my day easy, which my whole day was full of Judy's. Up until the age of 59, Judy happened to have a doctor who was still in the genetic dark age. Judy comes in at the age of 60, and I asked the fateful question, how old were you when you had your breast cancer? Because now I know it's important. She goes, I'll never forget. Got the call on my 40th birthday. So she was 20 years out. I'd lost track of that time. And I go, uh-oh. Well, we're going to need to talk about this. I said, luckily, we didn't have any other breast cancer in your family. And she goes, well, that's not true. My dad's sister had breast cancer after I did. Well, that's news to me. Judy, why did you never tell me that? Yeah, fill in the blank. Why did you never ask? All right, so this points out that, I wasn't doing the simplest of things in that regard. Well, the guidelines say at 45 or under you get tested. So even in Kansas, we know that 40 is less than 45. So that leads to her getting genetic testing. And of course, she's BRCA2 positive. She goes on to have her lady parts removed and the other breast removed. Everything's good. Whew, dodged a bullet. Father and daughter Jenny carry the same mutation. There they are in red. Attention turns to Jenny, the daughter, who I've also owned for 20 years, because she always came in with mom during her chemotherapy in those days. Describe to Jenny what her risks are. You remember from those curves? 80% chance of getting breast cancer in her lifetime, 20% chance of getting ovarian cancer. I'd like to keep my breast, please, but I'm done having children. You can have my ovaries and tubes. So she has a CA-125 level and a sonogram and a pelvic exam, and everything's good. She goes on to surgery and has a small serous carcinoma in her fallopian tube. Unless you think that that's a rare gee whiz phenomenon that occurs in up to 10% of BRCA-positive women who have preventive pelvic surgery in various studies. So Jenny and Judy, after all of this, think, and they tell me this to my face, you're like the smartest doctor ever. Because I started the chain of events that led probably to saving Jenny's life. And while I happily accepted their adoration, I think privately to myself, man, I totally dropped the ball in this family. Here's what haunts me, and here's what I want you to take away from this. What if I'd waited one more year to ask Judy the simplest question, how old were you when you had your breast cancer? Or the second question, is there any other breast cancer in your family since the time I took your family history 20 years ago? Where would Jenny be 1 year later? Well, for those of you who know ovarian cancer, stage 3 something, okay? So you have to find these people, the Judys, in the survivor population if we're going to have any chance of helping these folks. Anyway, Lorraine has ovarian cancer at the age of 51. She has standard chemotherapy, surgery, etc. I believe I read somewhere on an earlier slide, 100% of ovarian cancers get tested. So she does. BRCA testing, and it's negative. Okay, well, I've done my duties, right? I did what I said supposed to do. We're done. Look at the family tree. Mom had breast cancer. Father had colon. Grandma had endometrial cancer. Right? You probably don't know the answer to this question, but we're not so much done. Let's look at ovarian cancer genetics for a moment. Epithelial ovarian cancer, that is, we're not talking germ cell tumors and whatnot, we're talking standard ovarian or fallopian or primary peritoneal cancer, has the strongest connection to underlying inherited genetic defects of any cancer out there, any epithelial cancer, okay? 15 to 20% of all cases. That is why it's 100% should have genetic testing. The majority of those are BRCA, but another percentage are Lynch syndrome, and now we know about several other genes that are in the mix. So I've mentioned Lynch syndrome several times. Let's take a little closer look. These are the cancers that make up the syndrome. First thing you notice is that's a lot more cancers than I'm used to dealing with BRCA. And this is where historically, unfortunately, lots of doctors sort of check out. Oh, I can't keep track of all of those. All right, so I can't do this. Oh, yeah, you can. You see the big line here separating these, all right? These are the biggies. So if you came into this not knowing anything about Lynch syndrome, leave knowing these four: colon, endometrial, ovary, stomach, 2 GI, 2 GYN cancers. They're the big ones, right? If you can't keep that straight, then you might have some other issues going on. Look at these cancer risks. Colorectal, up to 80%. Endometrial, up to 70%. Ovary and stomach in the 10% range. Those risks are just as high as what I described in BRCA, right? Just a few minutes ago. The rest of the cancers are, generally speaking, rather unusual cancers, mostly in the abdomen. Notable exception are glioblastomas. How about some pink flags for, I gave you the red flags before. Here are some things, since we're talking Lynch syndrome, to be on the lookout for. Cancer of the ureter or renal pelvis. Is that a big epidemic going on? There's a ton of those? No, those are rare cancers. When you see one of those, stop in your tracks. Look for more clues of Lynch syndrome. Same with adenocarcinoma of the small intestine. Not a common cancer, but it's part of Lynch syndrome. So just by itself, that should cause you to pause. We're going to talk a little bit more later about the development of colon cancer soon after a clean colonoscopy, all right, as a clue, all right? And then sebaceous skin tumors, we're not going to talk about that. Back to Lorraine. If I look at Lorraine through my Lynch glasses, all right, for my red flags, I see ovary, colon, endometrial. She gets tested for Lynch syndrome, and she does, in fact, have a mutation in one of the Lynch genes, all right? But I had to go through 2 steps to get there, and therein lies the problem. Even if we have doctors that are doing their 100% testing duty for BRCA, do they see the clues that would cause them to go beyond that? And again, what I want to submit is, in today's world, the technology allows us to do all of this in one step, so that we don't have to do it in stages. We do the whole thing once. Before I move on, I want to ask this question. If I take all the people in the United States that are walking around with a BRCA mutation, whether they know it or not, and all the people walking around with a Lynch mutation, whether they know it or not, make a ratio of BRCA to Lynch in the population. Which one of these do you think is closest to being the right answer? 20, 10, 5, or 1 to 1? Shout it out. Come on, let's. There's door prizes. Let's go. It's like Oprah. Come on, let's go. We have 1 vote for 20 to 1. 5 to 1. I feel like I'm auctioning this off here. It's the, all right, let's move on. Correct answer is, drum roll, D, 1 to 1. Lynch syndrome is just as common as BRCA. The cancer risks are just as high. And yet I would suggest to you that in our own practice, at least going back a few years, not anymore, and as I go around the country, BRCA is being talked about 100 to 1 compared to Lynch syndrome. When was the last time you saw Lynch syndrome in the news? Ever? All right? Not even in March. In October, in Breast Cancer Month, you hear about BRCA every time you turn around. And that's good. Where's the discussion in March? If you get the feeling I might be a little bit passionate about Lynch syndrome, you got that right. Here are the real numbers. BRCA, 1 in 400 Americans, unless you're Jewish, 1 in 40. Lynch syndrome, about 1 in 450. All right? Lynch syndrome is an inherited defect. I mentioned these mismatch repair genes. I'm not going to go into what they really do. But all you really need to know is if you're born with one that's defective, right, one of these 5 genes, you enter into a world of genomic instability. The genome referring to all of your DNA and all of your cells, and it's unstable. And that's not a good thing, all right? And it really programs you to get those variety of cancers. And I've already mentioned it's terribly under-recognized. Let's just look quickly at our same list before and say, well, which ones are preventable, all right? That's what we really want to care about. Well, isn't it lucky that the top 3 are very, very preventable? Colon cancer, I can prevent more than 80% of those with annual colonoscopy. Endometrial, preventive surgery. Ovary, preventive surgery is about 90% effective. Stomach, we're not as sure about. Others, we're still working on anything that can then prevent or even be early detection on these. But here's the big three. So again, we're accompanied by downstream strategies that make finding these people worthwhile. Here are the management for Lynch syndrome, the risk management. Colonoscopy starting at age 25, unless there's somebody younger than that. Annual colonoscopy after 30. Not every 5, not every 3, every year. Start monitoring for the endometrial and ovary at least by age 30. Our target is to remove the uterus and ovaries after childbearing is done. In 35 to 40 is our target age. We do upper scopes. We do some simple urine testing. We're evolving things to screen for pancreas cancer. It's in progress. We'll get there someday. But again, we have risk strategies available. Let's meet Nancy. I meet her when she's 50 years old. She had colon cancer at the age of 42. It was in the ascending colon. That's one of the hallmarks of Lynch colon cancer, is to be in the higher part of the colon as opposed to the rectum and sigmoid. Not always, but frequently. She had had a right hemicolectomy and chemotherapy. Her cancer was diagnosed at her first ever screening colonoscopy, which was done because Dad had colon cancer at 52. All right? So somebody looked at the family history, and that's why she was there. Uncle had colon cancer. Grandma had uterine cancer, and then colon cancer. That sounds suspicious to anybody else in the room besides me? All right? But I don't meet her until 50. All right? Here's red flags all over the place. Here's the family tree. Bam, 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 bam. All right? Between the ages of 42 and 50, what do you think she was doing? She was seeing doctors all the time, right? Following up with oncologists, following up with surgeon, following up with GI, following up with gynecology, family practice, all this stuff. Nobody in that 8 years picked up on that story. She got picked up as soon as we put in our survivor. She was following with us as well. As soon as we put in our mechanism for finding survivors, and she had Lynch syndrome, MSH2 mutation. No surprise. She went on to have her uterus and ovaries removed, which thankfully had not done anything bad in that 8-year interval. If you care, or if your doctors care about liability, by the way, had that happened, had she gotten ovarian cancer at the age of 48 while we were messing around and not doing anything, we would have gotten to meet, perhaps, some people wearing suits that we didn't want to ever meet. Here we go. Here she's red. Here's the rest of the family. Her son has it. Her brother has it. A cousin has it. Her other sister's negative. All right? So now we have opportunity to prevent cancers that were destined to occur by putting these people in the right kind of program. Easy? Now, I mentioned this accelerated timeline, or this close interval after colonoscopy. This genomics instability thing in Lynch syndrome changes the biology of cancer development. It doesn't cause people to have more polyps, all right, in their colon. But a typical colon cancer, from the formation of polyp to cancer is born, typically is thought to be 7 to 10 years, right? That's why we do 10-year colonoscopies in average risk people, all right? In Lynch syndrome, when that polyp is formed, it wants to be cancer real bad, all right? It's on a rocket sled because the genome is unstable. Bad things are happening. So, commonly, cancer is born 1 to 3 years out from the formation of that polyp. Well, if you're not there with your scope during that interval, you're going to miss it, okay? So, beware the colon cancer that came out of nowhere. When you hear a patient say, I don't understand how this happened, I just had a scope 2 years ago and it was clean. All right? Think Lynch syndrome. And it's also the basis for the annual colonoscopy recommendation. Here's Kathy, 51 years old, with a cancer of the cecum, again, a high cancer. She had abdominal cramping. She was 18 months out from a normal colonoscopy. And in today's world, normal means I got a real nice picture of the cecum right there in the chart, clean as a whistle, right? And now she's here with stage 2B, cecal cancer. Her first colonoscopy was at age 25 because her brother had colon cancer at age 23, all right? That should be a big siren going off right there. She gets a right hemicolectomy performed, all right? Her brother died at 23 with colon cancer. Father had ureteral cancer. Where have I heard that? Pink flag, all right? Aunt had pancreas cancer. Grandma had uterine cancer. 3 of these were youngish, all right? Red flags. Here's the family. Here's Kathy, her brother, dad, grandma, all right? Has a genetic evaluation. She's got Lynch syndrome. Nobody's surprised. Well, the colon surgeon's kind of surprised. And the GI doctor's kind of surprised because they never even gave it a thought, right? The only reason she gets found is because she's sent to oncology afterwards, and one of my partners goes, ruh-roh, this is not good. There she is in red, and the point of this is she had to undergo another operation to remove her uterus and her ovaries. Her surgery was not urgent. Wouldn't it have been really neat if somebody had put together the clues before she had her surgery and we figured out she had Lynch syndrome so that when she has her right hemicolectomy, she also could have had her uterus and ovaries removed, right? So it's just amazing how the clues so obvious are ignored. Last thing about this case, and that is her nieces. These are the daughters of the brother who had colon cancer so young. What do you think they've been doing their whole life? Colonoscopies every time they turn around. Started at the age of 12, all right? And been getting scoped variably every 2 to 3 years ever since. That sound like the right thing to do? Do we ever recommend that for somebody who had such a weird thing happen in their family? Yeah. We paint the whole family with the same brush and say, tell your children they need to be scoped early and often, or tell your siblings or whatever. Wouldn't it have been better somewhere back in time to figure out, even before Kathy's cancer, figure out this family? Because one of those nieces has the bad gene, and one of them doesn't. And as we already talked about, her risk of getting colon cancer, same as the normal person. Her risk, 80%. She needs colonoscopy more often. She needs it less often. See you when you're 50. All right? So see how that much better that is than just continuing to do painting the whole family with the same brush. And there's the rest of the family. Again, other opportunities to prevent cancers. So let's just look at women separately for a moment. This is an equal opportunity syndrome. But women, since 2 of the top cancers are female, they tend more often to present with one of the female cancers a little more often than they do colon cancer as the first cancer. So there was a nice study done a couple years ago, published, about endometrial cancer patients with Lynch syndrome and what happens to them over time. 20% of them had another Lynch cancer within 10 years. Half of them had another Lynch cancer within 20 years. Why did they have another Lynch cancer? Because nobody figured out that they had Lynch syndrome and nothing was done to prevent those cancers. All right? The large majority would have been preventable. So endometrial cancer then, if that's part of your influence area, is a gold mine of patients that have been ignored in the past that need to be addressed. I'm going to skip that slide. I'm going to talk about Carol. Carol, 64 years old with cancer of the uterus, has a complete hysterectomy, early stage. It's all good. She just recently had a colonoscopy, which is normal. That's good. Grandma had ovarian cancer at 61. And there's the family tree. Carol, grandma. On her father's side, father died young from another cause and had no siblings. So this is an instruction here that sometimes when you're looking for that slam dunk family history to help you and it's not there, sometimes it's because there's no people there. No people that live long enough to get the cancers in question. And that's what happens right here. But anyway, So not exactly a slam dunk sort of situation, but in this effort to help with the endometrial patients, we use some computer models now. We do some testing on the uterine tissue frequently, immunohistochemistry. Long story short, we were able to find clues that pointed to her diagnosis of Lynch syndrome. And what comes out of that is her sister and her son also had the syndrome. All right, so we can get better if we just employ the tools that we have. All right, let's move on and say, how do we solve these puzzles when we face them? Testing the right genes to solve the puzzle. We're mostly talking about BRCA and Lynch family puzzles. The syndromes are straightforward. We've had testing now for 20 years, commercially available, that doctors can order. We've got guidelines galore. So we ought to be pretty good at this by now, wouldn't you think? Let's look at the report card for where we are. To date, maybe 10% of all the BRCA carriers in the United States have actually been diagnosed. And fewer than 3% of the Lynch patients in the United States have been diagnosed. And we wonder why the hits just keep on coming, and wonder why patients keep coming in and having to meet people like me in oncology that they never wanted to meet. So part of the problem is the approach we take. Here's the old approach. You might be familiar with it, where we would look at that FAMP and we'd make our best guess. I think this is BRCA, and we would test for that specific syndrome. Okay? We try not to do that as much anymore because it leaves a lot of things on the table. Because we have this new technology, sort of generally referred to as panel testing, testing a panel of genes at the same time. The technology is next generation sequencing. If we use panels correctly, it can be more efficient, more accurate, and cheaper. Win, win, win. But what genes should we put in the panel? Right? There's a lot of labs out there now that can do next generation sequencing. Which labs, or which genes are we talking about? Humans have 30,000 genes, so pick which ones. Many labs do panels that are so-called disease-specific. A breast panel. It might be BRCA, and some or all of that, like third slide list of breast cancer genes. Or colon cancer genes. And on the surface, that makes sense, seems logical. In practice, it turns out not to be so. Another approach is to use a panel that intentionally crosses over different cancers, different syndromes, right? Casts a wider net, all right? So that's a different approach. So here is one of the popular ones out there, the 25 gene panel. And I've listed over here the 25 genes. Here's my BRCAs and the cancers associated with BRCA. Here's my Lynch genes and those cancers, and a handful of the others, okay? It's not important that you know everything on that. But the modern approach is then we start the same way. We look and see, does this patient meet criteria for BRCA or Lynch? If so, that's my ticket into the broader 25 gene panel, all right? Now, since we're turning over 25 stones, we're more likely to find what's really underneath one of them. We're also more likely to, if we get negative tests, for it to be a true negative, right? Unlike the old days when we did BRCA testing and said, well, man, good news, your BRCA is normal. She goes, well, what about the other breast cancer genes I read about on the internet? We didn't test those. So the negatives are more likely to be true negatives. Any case. So one of the things that was a issue when this first came about was doctors saying, I don't recognize some of these genes. I've never heard of them. If I do this test and I get a result back and it's positive, I don't know what to do. This slide shows you where we stand today. 2016, of those 25 genes, all but 2 now have nationally accepted guidelines for the management of the risk, right? So providers can't hide behind, I don't know what to do. Matter of fact, in the 25 gene panel, when you get the report, it tells you what the cancer risks are right there on page 3, and on page 5, it gives you the guidelines for managing those risks. So the clinical impact of this, turns out there's a lot of overlap between BRCA and Lynch that we never perceived. We've got studies showing that doing it the old way misses about a third of all the mutations. That's leaving a third of them on the table. Gene panels that are disease-specific, the breast panel, the colon panel, also misses a whole bunch, and I'll show you my data here in a second. Let's meet Janice. She has breast cancer at 55. Mom had ovary, aunt had breast, uncle had pancreas. Where have I heard that combination of cancers before? All right, sound familiar? Here's the family tree. Sure looks like something's going on. There is a uterus there. There's a colon there. How do I look at that? How am I going to solve that? Well, here's several syndromes to consider. How about BRCA? I got 2 breasts, an ovary, and a pancreas. This looks pretty suspicious. How about Lynch syndrome? I've got a colon, a uterus, an ovary, and a pancreas. Or there's another syndrome called Cowden. Which one should I do first? What sequence? Oh, wait a minute. Let's just do them all at the same time with the 25 gene panel. Janice has Lynch syndrome. I don't care how many breast panels you did on Janice, you weren't going to find Lynch syndrome. It's not part of any of them. Here we go. Here she's positive, and here's what happens with the rest of the family. And yet again, we find somebody who's had no cancer and is on the railroad tracks. I don't know that Lynch syndrome caused Janice breast cancer. I just know that when I'm done handling her breast cancer for the rest of her life, I have to pay attention to her colon, her uterus, and her ovaries, right? Otherwise, we're going to be right back where we started. Meet Warren, colon cancer at 49. He's cared for in another city, surgery, chemotherapy. Shows up on our doorstep 8 years later because he got a low platelet count. But just because he's there for hematology doesn't mean we don't take a cancer family history in our practice. And there we go. Mom had uterus, grandma had colon. He had proximal colon at a young age. Come on. This is obvious, right? A couple of breast cancers on his dad's side of the family. Here is the family tree. All right, boom, boom, boom. And if you came into here knowing anything about Lynch syndrome, you might have heard about something called Amsterdam criteria, which is what we used to use to analyze the families because we had no other way of sorting this out. And here's a family that meets Amsterdam criteria. Slam, dunk, that's Lynch syndrome. Let's prove it. While we're at it, let's do the whole 25 gene panel because it costs the same as doing 5 genes. Let's do 25. Warren doesn't have a mutation in any of the Lynch genes. Warren has a mutation in BRCA1. Surprise. Here we go. Not a big deal for Warren himself with his being a male with BRCA1. But Warren's 2 daughters carry the same mutation. You can see where the BRCA1 came from. Here's a young breast cancer, and here's an average age breast cancer. There's only 2 of them. It's not very compelling, but they happen to be the only 2 women on that side of the family. All right? So you can't be looking for the slam dunk, and who's even asking about them in a colon cancer patient? Any case, for the 2 daughters, breast cancer was not even on their radar. This is a great grandma, great aunt. Nobody was worried about breast cancer in these 2 women, and yet here they are, planted firmly on the aforementioned railroad tracks. The older one, she says, oh, get me off, all right? And so she has her pelvic surgery, and then she went on to have a double mastectomy. She wanted to have another child, so she's under high-risk surveillance while we're waiting for all that to happen. Again, this wouldn't have been found on a colon-specific panel, and this is a life-changing, this is a life-saving finding for those 2 daughters. So before I show you my experience with the 25 gene panel, I just want to make a comment about what my life was like before the 25 gene panel. So these are the old days under the traditional approach. This represents about 7 years of my work, 2,000 genetic consultations, 240 people I diagnosed with cancer-causing mutations. BRCA, Lynch, polyposis, the big 3, a handful of others that I had to go past the fork in the road to find, but not very many was I able to find. But what I want to point out here is more than a third of those patients were not newly diagnosed. They were in our survivor population. They were Judys, all right? And Nancy's, things like that were under our care that we'd been missing over and over and over again. Please, in your domain, have a systematic way of identifying these folks. With my 25-gene panel, I pulled 9 months of data, 240 patients, in which I found 47 pathogenic mutations. Here's my big 3. Now I have a whole much bigger group of other mutations I found. Makes sense. Turned over 25 stones. Found other things. A third of them I would have missed in the traditional way. I never would have gone far enough or been able to go far enough that I found. But here's the other thing. 9 of them would have been missed if I had used the appropriate disease-specific panel. I showed you Janice. I would have missed her Lynch with a breast panel. Showed you Warren, would have missed the BRCA with a colon panel. And I'm not even counting Warren's daughters. Right? So if you get the feeling like I might not be a fan of disease-specific panels, even though they seem logical, you got that right. Right? It leaves, for me, too much on the table in terms of actual diagnosis. So our last part of this was to use testing methodology that gets the best chance of giving the correct answer. All right? And I'm really talking about accuracy in testing. All right? I'm not going to go into great detail, but just to say, next generation sequencing, the modern technology, is being done by a host of laboratories. All right? They're all using the same machines, but they don't use the machines in the same way. There is a big variability for what they're actually doing on the inside of that machine. So you can't be fooled into thinking that, oh, they're using next-gen sequencing, they're just the same as everybody else. This is not a CBC done on a Coulter counter, which is pretty much the same from place to place. All right? In order to find all the mutations that you want to find in the genes we're looking at, right, that next-gen platform has to go through a process called optimization, all right, and validation, which means you have to be able to find everything you could find with old technology, at least on the new technology. You have to prove that. That's a validation study. At this point in time, only one laboratory actually has an optimized platform with published validation studies. All right? For me, that's the warm and fuzzy I need when I'm talking to Mrs. Jones about her genetic results to know that we did it the best way we could. Now, let me explain that just a little bit more, and don't be scared by this. I'm going to take you down Genetics 101 very quickly, and I think it'll give you a feel for how they can differ. A gene to be analyzed, all right? The exon is the part of the gene that does the actual business end. It's the one that codes for the protein that that gene is going to make. The intron is a spacer, all right? It's supposed to be inert, more or less, spacing between the next exon on down. Here is the code of molecules on that exon. That's the patient's code, all right? We'd like to know, is that the normal code? So in order to do that, we bring up next to it a primer that carries the normal code. We know what the normal code's supposed to be for every part of every gene, okay? In this case, it's the same. So that part of that exon is normal. Make sense? Yeah, so far? Well, what if it's not the same? It's supposed to be an A, it's a G. That's a variation. We need to classify that. Is that worrisome or is that benign? That's one of those things that's just the difference between humans, right? That's the process there. But these are then the things that we're looking for. How do we find them? Well, we have to use primers that are extensive across the exon. They're piled up on each other, called tiling. Turns out the intron is not as inert as we thought. Cancer-causing mutations do occur in the intron. And we have to look at enough molecules of patients' DNA to get rid of the genetic noise and have the abnormality pop up. That's referred to as depth of testing. All right, I know that's too much. Let me show you graphically. Here's my exon, primer number 1, primer number 2, extending into the intron and covering that. The next group of primers tiled up like bricks, okay, or subway tile, so that every part of the exon is being looked at least twice by different primers, all right? But what if I've got an area right here that I'm really concerned about? For whatever reason, I might tile up additional primers so that this area is being looked at 4 different times, all right? And then I want depth of testing. I want to look at least 1,000. That's the magic number, all right? That's an optimized platform. Maybe you'd like to see a non-optimized platform because this is what some labs are doing. Here you go. Gaps between the primers, no second layer, no tiling, no extension into the intron or minimal. Depth of testing, some are using 50, all right, in terms of that. So, makes me a little worried, but this is cheaper. So when you hear somebody going, yeah, we do it, we do the same things, we got the same name, but we do it cheaper, beware, you may be leaving some stuff on the table. So if your own blood's going in, or your daughter's, or your whatever, you want it to go here or there. If you think this isn't real, meet Gail. Gail was diagnosed with breast cancer at the age of 44. That's automatic, right? She's less than 45. Mother had breast cancer at 44, grandfather pancreas, there's uterus cancer. Gail gets tested at a laboratory using a disease-specific breast panel in a lab that doesn't have published validation studies. No mutations were found. Normal. Yay. All right. Off we go. She has a lumpectomy, radiation. It's all good. She's on tamoxifen. 9 months later, her cousin is diagnosed with breast cancer in another state at the age of 39. That doctor there uses the 25-gene panel at a laboratory with a fully optimized platform. She's found to have a BRCA2 mutation. What does her cousin do? Hey, Gail, guess what? All right, I know you just had breast cancer, but I have a bad gene, all right? And so I'm supposed to tell you and everybody else to get tested. And Gail says, well, here's the cousin in red. Gail says, not to worry, I've already been tested for that gene. I'm good. Really? Well, that seems odd. Maybe you should talk about that with your doctor. I'm going to send you my report. So she does. Gail goes into her oncologist at the next visit, tells him the story, and he goes, yeah, that's odd. Why don't we test you, Gail, at the same lab that your cousin was tested at? We'll just test you for that mutation. You either have it or you don't. She had the same mutation. Bam. So if you think there's not a real difference, there is. In every city I go to nowadays, I hear at least one horror story like this. So for me, I want the most accurate lab results I can possibly get, and that's the way I am with everything. Any test I order, I want the best. Here's the rest once it all gets figured out. So you get what comes from that. So let's wrap up here. Hereditary syndromes are more common than a lot of people think. The risk management strategies are highly effective. We've got to find those people on the tracks. It affects future cancer risk. It may also affect management of the cancer at hand. That's a timeliness issue. All right? This is a quality of care issue. All right? Genetics is no longer on the fringe of medicine. It's no longer optional. This is mainstream stuff. And every kind of doctor, gynecologist, surgeon, oncologist, has a mothership organization that's telling their doctors, this is part of what you need to do, all right? And yet a lot of them aren't doing it yet. Lynch syndrome, just as common as BRCA. Cancer risk just as high. Please, in whatever role you have, make a special effort to find the Lynch patients. There are many carriers among your survivor population. If you don't systematically screen, you will miss these people. The guidelines do evolve pretty much every year. There's some kind of tweaking to it, and you have to be aware of the changing guidelines. Multi-gene panels make puzzle solving much better. In my opinion, disease-specific panels don't do it as well as the broader panels, and I showed you some examples of that. And in my opinion, a demonstrated accuracy in testing in our best of all worlds should rule the choice of where the testing is being done until they all catch up. And in summary, every doctor, and in this case, every nurse, has a role to play. You've got to function to find these people, help us all out, doing it together, to maximize the number of cancers that were destined to occur that we can now prevent. And I will stop right there.